Hi, welcome to this week's Nurse Coach Duo. Angie and I are super excited to have Dr. Hertel back here talking with us about all of the great information she got from the Menopause Society annual conference. She brings us her hot tips and takeaways from each day, and we learned so much new information that's coming right off the hot off the presses, straight from research, straight from the experts and the Menopause Society. And we're really, really super excited to bring all of this information to you. If you haven't seen Dr. Hertel before, she has been on this podcast twice, and I'll tell you a little bit about her. She is a board certified osteopathic family medicine physician and a certified menopause provider, which we always recommend that you seek certified menopause providers. She's the founder and CEO of Osteopathic Midlife Health. It's a telemedicine practice that she's dedicated to midlife and menopause care. Dr. Hertel is such an advocate for these women. She's super passionate about making sure that we advance education, that her clients, her patients, and her social media followers understand what's going on in their body and how they can get help for themselves. And she does not disappoint in this interview with a ton of great takeaways from the Menopause Society. You can find Dr. Hertel on social media. She has a very large presence there, and you can also find her as a co-host of the Dusty Muffins podcast. But right now, you're going to find her right here on the Nurse Coach Duo with Angie and I talking all things Menopause Society education. We're super excited. We hope you enjoy it, and please don't forget to subscribe. Before we dive in, just a quick reminder. This episode is for educational purposes only and isn't medical advice. If you're dealing with a health issue, please check in with your healthcare provider.
Hi, welcome to the Nurse Coach Duo. My name is Angie McGuire. I'm the owner of Coach Angie.
And hi, I'm Jen Schroer. I'm the owner of Clarity Health and Wellness Coaching. And we're really excited to have Dr. Hertel back with us today to talk about everything that she learned, all the key hot topics at the Menopause Society annual conference. So welcome, Dr. Hertel.
Thanks. It's glad to be back again. I really appreciate it. This was so fun and like so last minute, like, yes,
I know.
let's do this. I always, and the big thing on these takeaways is I will preface it with that these were my key takeaways from the conference that I thought were really interesting and really important. It may not be what other people's key takeaways are, but
Sure, yeah, of course. Well, yeah, we're just really excited that you were able to do this so quickly because I know you just got back but we wanted to get it while it was fresh in your brain and had
yes.
kind of some of the excitement. I'm sure you have a little exhaustion as well, but some of the excitement. Angie and I were really bummed not to make it. We are both Menopause Society members and loved the idea of having the conference, and we've been watching a lot of clips and stuff. So we're really excited to hear what you have. So I'm just gonna say, let's just kind of go day by day. What's your day
Yeah.
one key takeaways, and we can kind of talk about them a little bit.
Yeah. So day one was I really liked day one. It was maybe one of my most favorite ones because I really felt like they gave perimenopause just a really nice overview. And we really moved away from perimenopause being this like, mid to late 40s and you have to have hot flashes and night sweats. They really paid attention to what we've all been hearing, which is that it often starts in your mid to late 30s and early 40s before cycles actually change. So, number one is that, perimenopause starts earlier than most of us thought or think or perhaps were taught. That hormonal variability is that driver. So it's those fluctuating FSH and estradiol, and progesterone to a certain amount as well that can cause those mood changes, sleep changes, cognitive changes, which I don't know about, you ladies, but that's a lot of times what they'll come to me first, even before they're having their cycle changes.
Yeah.
And so that was a big key takeaway. They again talked about the straw, which I just think is, when you're talking with the community, straw is really for like our clinician colleagues to take a look at. But it still was nice to really look at like how reproductive aging and staging is working in the straw 10. They talked too about like mood changes and anxiety. There was a really great picture of like perimenopause mood and it was lines all over the place. And I know on my Instagram, I was like, anybody else feel this
Yes.
besides me here? And so just gave a
I see
lot
that,
to
yeah.
that. Yeah, right? Like we see that so much. Like one day you're fine, one day, I mean, everyone is asking us that. Like, Mom, you were like happy and now you're yelling and now you're sad and now you're just like, that's what my estrogen is doing. So it was nice to kind of just, put that out there to really validate that we see that, we hear that, and now we're also educating about it. So, that these mood transitions really do peak in that late, sometimes that mid to late transition get worse in that late transition, and that's due to that estradiol, real instability there.
Yeah.
Um, there was a talk about abnormal uterine bleeding. That was their last year as well. And again here, and that it's not always hormonal. We need to make sure that we also rule out other causes of abnormal uterine bleeding, right? Fibroids, adenomyosis, other gynecological things that especially myself, I'm not a GYN, so that I would refer to my GYN colleagues for. That again, validating early symptoms. That was really kind of a nice theme, just really saying that, like, when women
Yeah.
say they don't feel like themselves or that they feel off, that we need to be listening to that.
Yeah.
It's
Here,
really
here.
right. It's
I'm
women
I'm
know.
so like thrilled that that was, yeah.
Yes. And
Yeah.
then,
I mean, I'm so thrilled that that's like how they came out like blazing. I'm
yes,
glad they started
exactly.
with that,
I
right?
mean, we
Like
were a
that's
lot of
exciting.
clapping in this, and with the perimenopause lectures and the mood lectures and things like that too. Also that, perimenopause, as we've all talked a lot, is a window of prevention, right? That we want to make sure that we start our cardiovascular screenings, our bone screenings, our cognitive screenings earlier rather than later. And then again, the last thing would be a holistic care, that we need to integrate, mental, metabolic, urogenital health, not just talking about hot flashes, although, as you know, I'm a big proponent of no hot
Yeah.
flashes because of what they do, but that we need to start thinking about all of the other parts that come along with it too. So that's kind of summed up day one.
That's awesome. Yeah, that's super exciting because I agree. Like the whole like perimenopause, whenever everything started coming out, it was all about menopause. And it was like, what about this whole big thing over here? I really think
Yeah.
this is what we're talking about the majority of the time. So it's really great to
Yes.
have them recognize
Yes.
that. And I really love that a window of opportunity or a window of prevention and, encouraging providers to validate those
Yes.
symptoms. Huge,
Yes.
huge, huge, huge.
And they need to start validating, because oftentimes, when I get clients, it's because they've been rejected by their other practitioners, or I mean, we still hear perimenopause doesn't exist. We still hear it, and
Wow.
it's not an abnormal thing for someone to be told that. And so, it was nice to see that now at the society meeting, and it getting the, just the care and the education it deserves. So. Um, and day two, you guys ready to go into day two? Or any other questions about day one?
Angie, you
Okay,
got any
cool.
questions? No? All right. Yeah,
All
go for
right.
it
All
then.
right.
No,
So,
I mean, I'm just so happy we're talking about perimenopause. So
yeah, I know. I know. We were
I think
really
I have a
happy and
lab.
excited about that. um, Day two was my key takeaways is there was a really great lecture on, longevity. Longevity, sleep, metabolism was kind of like the focus, or at least kind of what stood out to me that day. And, um, really talked a lot about focusing on health span and not lifespan, right? Like it's great for us to live long, but me personally, I would rather have a healthier life as I'm living longer than to
Yes.
have a longer life that's unhealthy. And, I can't get myself out of a chair. I can't get to the restroom. I can't do my just simple ADLs of life, right?
Right.
And so they really talked about that, like, aging is a root cause of chronic disease. And so we really need to focus on that health span. They talked a little bit about ovarian aging, linking to brain and metabolic aging, was really fascinating. Reproductive hormones, key to longevity signals. So there was a lot of research that really looks at like ovaries and doing testing on ovaries, and do they still do what is their role after menopause? It was really fascinating to me, very much over my head as far as genetics and things like that, but fascinating nonetheless. So it really, I think, is going to make us stop and think about taking these ovaries out. So, what are they doing? It really looks like they may be doing something even long after reproduction for us. So that was really fascinating.
Yeah.
Um, and then muscle is the, menopause biomarker, right? We have got to protect lean muscle mass to extend our health span. I mean, I talk about this all the time. Protein, 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 muscle, 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 muscle. We have to do it. No more, our jazzercise and cardio every single day. Like, in order for us to live longer and stronger, we have to build muscle and we have to preserve that lean muscle mass. So, we burn more with the more muscle that we have, we burn less, the less muscle that we have. And that's just is what that is.
Yeah.
We talked again about like metabolic changes, so how visceral fat increases post-menopause, even if the weight is stable. And we also know that as we age, just a part of aging, and I try to make that always really clear too. It's not just midlife women, but everyone, as we're aging, we lose muscle mass and that gets replaced with adipose tissue, which is less metabolically active at rest. And so, again, the more that we preserve that muscle mass, the more metabolically active we are at the same weight, right? And so, also, that this increase in visceral fat is also what drives insulin resistance and inflammation. So when I don't know, I have a lot of women that'll say to me, like, my hormones feel great, and but I'm inflamed and I feel inflamed. And so we really have to start talking about then lifestyle changes in order to get that inflammation down. And yes, the hormone therapy can be a great base. It does not cause weight loss, but what it can do is help you sleep and help you feel better and get rid of your hot flashes, which means you feel better. And then you are more inclined to make all of those lifestyle changes. So, a lot about sleep too, that we know that sleep disruption disturbs metabolic risk. So even small sleep loss raises fasting insulin and glucose. So it's just fascinating to think about that. The old adage used to be like, oh, I can sleep when I die, right?
Yeah.
I mean, how many of you have, I mean, I've heard that. I've
Oh
said
my
it
gosh.
before.
Yeah,
I
absolutely.
have said it. And now we're just like, nope, that actually is going to decrease our lifespan if we don't get sleep. So it's really, really, really important. So we need to make sure that we are prioritizing sleep. The Mediterranean diet and circadian eating improves sleep quality, metabolic health, and reduces inflammation. So that's important. And we talked again, early detection of ovarian dysfunction can help alter long-term disease risk. And we talked about lifestyle over supplements. So exercise, protein, consistent sleep remain first line, even just, overall like longevity type medicine, right? And hormone therapy is a longevity medicine, right? That's kind of our buzzword these days. But if you're doing hormone therapy and hormone replacement, you are helping women live longer and increase their health span as well. So we talked a lot about supplements, but being really careful about where you're getting them from, that, how they're being put together, where they're vetted from, where you're getting, what do they really do, placebo effect versus non. So it was a great takeaway just to remember that you can get a lot of really great things from your food. I know I only have probably about 5 core supplements that if my patients need them, those are the ones that I tell them to take or recommend that they could try. So, yeah, that was kind of a lot, but that wrapped up for me anyway, most of day 2. Any questions on that?
No, I mean, mostly excitement than questions. I would love for you to say it again because you said it so quickly. What is that first line? Exercise, sleep. Say it again.
What did I say?
So your
Exercise.
first like exercise, sleep is it nutrition?
Oh, yes. Yes. Exercise, sleep, and nutrition.
Yes. That's
Yes.
your first
100.
line, right? Right.
Yes. Yes.
Yes.
Yes. Yes.
I love that.
100%. It's big. Like, those are things that just, there's not this quick fix at all. And so it does take some work, and it takes work partly because we're aging and those things just take longer, right? To
Yeah.
do. And we have to really focus. Our metabolism is different. It does change. Because I hear all the time, well, I'm just not doing anything different. But your body is
It's
different.
different.
Your body is different. Your body is aging. Therefore, you're different. So
Yes.
what worked when you were 20 and 30 is not going to work at 40, 50, 60.
Yeah.
So yeah, it's important. It's frustrating. I'm right there with you, you
Oh
know.
gosh, yes. Yeah. I do really like the point too that just because you haven't gained weight doesn't mean you haven't gained visceral fat. Because I
Yeah.
do think that there's so many people out there that say, well, I don't have any symptoms. And yet they're going on cholesterol meds
Yep.
or they,
Their blood pressure is going up.
their blood pressure's going up. Exactly. And they're
Their
not
fasting glucose
necessarily
is going
correlating
up.
it.
Their A1C is going up, right?
Yeah.
Mhm.
Yeah, exactly.
I see
So,
that often. I actually see that quite often. And we see that, and those are usually our osteoporotic risk women as well, right? They may be thin and they don't work out. Or they're cardio, but they're not, they don't have muscle mass. They're not in hormone therapy. So as they're aging, they're gaining visceral fat for sure.
yeah.
And so, and because of their lack of muscle mass, then that affects their bone density too. So yeah, that's really big. And really women and men should be doing these things in their 20s and 30s
Yeah.
for
Yeah.
their lifespan moving forward. It's just going to make it so much easier,
Right.
if we adopt those things early. So if I could tell my, 25-year-old self.
Right. Yeah. Exactly.
Yeah. So that was really great. Just a lot of sleep, a lot of nutrition, a lot of talking about, metabolism and health span and what to do in order to maintain health span, which I think is just so, so very important. So, um, day 3, cardiovascular and cognition was day 3. So, they talked again about cardiovascular disease being the number one killer of women. I think that we forget that a lot. That they also touched on that awareness is declining instead of inclining, especially in younger women.
Yeah.
So I thought that was a very interesting takeaway that, you know, it's, I make sure that I talk about that point even more now about cardiovascular disease being the number one killer, because I think we just don't think about that, right, at all. And so, midlife is the prevention window. We know that cardiovascular disease risk accelerates as estrogen declines. And they also talked about women's risk begins at lower blood pressures than we think. So current cutoffs underestimate a female's risk. They also talked a lot about like this white coat hypertension and making sure that we are sending patients home with what we call like home blood pressure or ambulatory blood pressure monitors, because oftentimes they are being missed and they're not coming back and they're really having higher blood pressures and they're not being monitored or watched. And so that increases our risk. They talked about 25% of women achieve their target blood pressure. So I thought the other thing that was really great was that they touched on lipids and that LDL lowering does save lives. We used to talk about statin therapy as it not really changing the morbidity and mortality in women. And the reason was because of the studies were lacking. So now we know that statins work equally well for women as they do men. So I thought that was a really great key takeaway. And I think that that is not well known at all. So I really
Agreed.
liked that. And that HDL is not a treatment target. I can't tell you how many times I have patients tell me, well, my HDL makes up for my LDL, right? And I'm
Yeah.
like, no, it does not. So it was nice to hear that again from a lipid specialist that no, it does not. So, and again, we can treat these women that maybe have a higher cardiovascular risk with a statin, and it works equally as well for them. Diabetes multiplies the cardiovascular risk. I always tell patients that if you have diabetes, you are you have the same risk as somebody who has already had one heart attack already, being diagnosed with type 2 diabetes. So it's really and really important to catch this. I was just talking with a lovely client today who we found her diabetes because we screened her.
Mm-hmm.
Silent, right? I
Right.
mean, she didn't feel it. She had no idea. But once we got those sugars down, boy, it's amazing how much better they feel.
Yeah.
And sometimes they'll miss that with menopause or perimenopause. And so I think, off on a little tangent, like let's not miss the low-hanging fruit as clinicians when we're treating women. They're iron. Can't tell you how many times perimenopausal women will have a ferritin that's like non-existent.
Right.
You fix it and you fix their energy, you fix their sleep, you fix their hair falling out, that you fix their exhaustion, their thyroid. It's funny, this week I had like all of those things, from patients, just a thyroid that wasn't caught and type 2 diabetes. And so, and not just women, but I think when we live with those things every single day, and then we don't know what it's like to feel better. So fix all of those things first. They may still need some hormonal support, but fix the low hanging fruit first. It's so easy and so easy to check for it. So I think as menopause clinicians, sometimes we can get into our head about just treating the hormones that we forget to look for those things. And so, it is a holistic approach. It really is. So that was really interesting. But diabetes is a four times higher risk in women than men, and multiplies that cardiovascular risk. So super, super important to make sure that those A1Cs are controlled and screened for. We talked a lot about GLP-1 agonists and the SGLT2 inhibitors with the cardiovascular disease that lowers both heart failure and cardiovascular death risk in women. So that was really great. So we know GLP-1s. Just there's so much up and coming with GLP-1s and what they do and what they can offer for patients. Heart health is brain health. We know that vascular protection reduces our dementia risk, and prevention over treatment. So again, really stress integrating sleep, stress reduction, diet, blood pressure control into, really every midlife visit is really important. So there was so many key takeaways, and underlying, again, sleep was a big one. We just heard it all the time at just how important sleep is for all cause risk reduction. And so I thought that was really great.
Absolutely.
Yeah, that's day 3. Any questions?
Can I just ask Dr. Hertel about the patient that you had, this client this week that you screened and you found that her sugars are high, and well, maybe not just this week, but they've come down, she feels better.
Yeah.
Do you think that, many perimenopausal women aren't getting fasting glucoses, right? Because it's,
or A1Cs.
You're not going to the doctors often. Yeah. So I hope our listeners are going to take away, all this information, but also and we coach about this, Jen, we advocate for people to get testing, but it's so important to be screened early.
Yes.
Right.
And you guys,
so it's just really
absolutely. In my family medicine, because I'll know I still do family medicine as well. I'm screening them in their in their 20s. I started doing blood work somewhere 18, 19, 20 years old. And so, these things, at least in their 40s, you should be starting to screen again, if not, depending on their body composition. If someone's coming to me and their body composition, is such that okay, you might be at risk here. I screen them, will do. And it's not just, like you said, your fasting glucose, but your A1C as well, because you may miss it with the fasting glucose, right? It could be just 99, which is still too high, but they're A1C. So I think they're easy things. Screening diabetes. You can bill that very easy. Screening lipid conditions, screening diabetes, most of them are going to pay for that, insurance wise and things like that. But yeah, once, if not, at least once a year. If you're only going to the doctors once a year, and my family medicine hat on, I'm just like, you need to have a physical once a year. Because
Absolutely.
really now our PAPs and our GYNs, those you may not, I do my PAP every 3 years. I'm like, you did the HPV screening. All right, buddy, I'll see you in 3. I'm not coming back every year. I don't need it. I'm low risk. If there's any vulvar issues, then yes, I'll call you up. But, so they may not be seeing their GYN even every year who's catching them and doing blood work on them, depending on that relationship. But their primary care provider should be doing those. Now, if they're younger, they may be doing it every 2 or 3 years, or at least their lipids, if they're completely normal. But if there's been a big body composition change, you need to be checking that. So
Yeah, we're big proponents, like Angie said, that of doing these tests. So actually, just like a quick plug is that our next episode after this one will be Angie and I and one other nurse coach sat down and talked about all the different labs that we recommend for
Yes.
our clients to get. And I always advocate myself. Yes, I could go and I could create an account to have labs done for the person, but
Good.
I advocate that they go to their primary because they need to have that conversation with their primary.
Yes.
They need to have that relationship. And
Yep.
if you can't go to your primary and ask for the things that you need that are general
Yeah.
preventative health to tell us what your metabolic risk, what your cardiac risk is, then you need a new primary.
Yeah.
Right? And
Yeah.
like, sure, I can do it all day for you, but I'm not your primary. I'm not the one who's going to take care of you when you get
Right.
sick. So you
Right.
really have to, I mean, advocate for yourself. And I think that I'm hoping that the more that people are hearing that, like we're getting, we already have
Yes.
strong women in our 40s and 50s, like we're obviously
Yes.
that's where the menopause revolution is coming from. But like we really have to do that because I've been working a health fair where we do a little finger pick, and we tell them what
Yeah.
their cholesterol is. And I'm like,
Yeah.
I keep telling people, oh, you need to go ask for this. It's for a
Yes.
lipoprotein. Hey,
Yep.
you need an ApoB. You need a fasting insulin. Like I'm just sending them back to their doctor because yeah, great, you got your finger poke. Nobody can take care of that for you,
Yep.
and other people need your primary needs to know what those numbers are. So you really should be doing that. So I
Yep.
love all of that. I really love that we're hearing that statins work.
Yeah.
I'm all, of course, for the preventative and the lifestyle changes. But we've put so many women on statins. Thank God we finally know that they actually worked.
I know. I know. And so, and and I still have patients that are like, well, it is scary, because then they're talking about some cognitive changes with that. But again, it's a risk benefit discussion.
Yeah, yeah,
Again, if your cardiovascular risk is high, what else, and you've done all the diet and I will give patients, I will give them time. I'm like, okay,
sure.
6 months, let's see what you can do. If you can do it, I'm all for it. Let's do it.
Absolutely.
But if not, then we need to talk about decreasing your risk, And so, and again, that's the number one killer of women. So we have to get that in our brain.
Yep.
Because I think, I mean, I even go through as, I'll be 50 in 2 years and I'm just like, oh yeah, I guess I am kind of, you just kind of go about your day and your years and you're just like,
Yeah.
oh, okay, all right. You know
Yeah.
what? We still need to make sure that all those things are being done to make sure that we stay as healthy as we can because again, it's great if you're going to live till you're 80, 90, plus, but not if you can't take care of yourself.
Yeah.
So,
Absolutely.
all right, last
Fantastic.
day 4. So that was really interesting. So hormone therapy and non-hormonal advances. So we talked a lot about that. So we know that 80% of women still experience vasomotor symptoms. You'll hear quotes anywhere between 70 to 80%. We know that menopausal hormone therapy is still the gold standard when it's not contraindicated. I really love that another key takeaway was individualized therapy. So every woman is nuanced. I love that. It
Yes.
really was a great theme. That was really wonderful to hear because I agree. I always say all my clients are, special little unicorns. And I don't know they're like, so what's it going to do to me? I'm like, I have no idea until you take it. Hopefully it's going to decrease hot flashes and night sweats. But you don't know. For some, you have to start super, super low and slow and some were like revving up because and up to higher doses because it's just not enough. So you just don't know what receptors are going to take up what medication and how they're going to feel. So I really liked that individualized therapy. The route, the dose, the timing should match risk profile and goals as well. So we have so many tools that we can use. Transdermal estradiol, preferred in metabolic risk, obesity, and of course, clot-prone patients. That there again is no mandatory stop age, right? So I still hear it all the time that patients have to be taken off, and I'm like, you guys, that we had a paper on that a while ago. And so we know that you can continue beyond 60 to 65 if benefits outweigh risks. And so every year that you see, or twice a year, however you're seeing your menopause patients, that those assessments could change. So you need to discuss the risk and benefit. Is your benefit still outweighing your risk? Okay, great. I'll see you next time. So that's really important. And I think it's important to continue having those conversations again for that health span. So are you still, and that means checking all those labs and biomarkers and are you still exercising? Are you still, doing all the things that you should be doing and not having any events in between? Because you still may, even when you're doing everything right, you still may have some type of event that changes your health. So, low dose vaginal estrogen, safe and long term for GSM at any age. 95-year-old grandma,
Yay.
45-year-old, doesn't matter. It is safe. In our breast cancer survivors as well, it is safe. So that's fantastic. They of course always talk about compounded hormones, lacking regulations, and the Menopause Society, we all kind of talk about, we go to compounded when the FDA approved medications aren't working, or there's an allergy, or it's unavailable in the doses that are needed. Or for example, if I need to add a testosterone to a vaginal estradiol, we don't have that. So that will need to be compounded. Or somebody that doesn't tolerate a micronized progesterone, sometimes that will need to be compounded out of the peanut oil or a peanut allergy, those types of things. So, and so we talked about then, non-hormonal options too. So your fezolinetant or Veoza, your SSNRIs, your SNRIs, paroxetine, venlafaxine, gabapentin, citalopram. So all of those types of medications for those who choose or who cannot take hormone therapy for their hot flashes and menopause symptoms. And then the new one, elozenitant, that just got FDA approved while we were at the Menopause Society. And so that I believe is coming available in November. So we just have another option for women who cannot take hormone therapy for their vasomotor symptoms. So that was really exciting too. Shared decision making is central to care. So that's really important. They again went over, making sure that you're discussing absolute risk and not relative risk, and to really clarify media myths. And I will tell you, and I'm on social media trying to educate, but it can be really hard when you have clients come to you and they're like, I want this, this, and this, and I'm just going to do my own thing, and I'm going to change my dosing and all this. And they're hearing that. They're hearing that they should go to their clinicians, demand this, and then they will just play with it as they want. Or they are seeing other non-clinicians and things on social media telling them what to do with their testosterone, progesterone, and estradiol. And I have a couple of thoughts on that. I love working with my patients and my women. And I think if they come to me and say, listen, I'm really interested in these 3 hormones, and then we talk about all of them and where they will be helpful, when you should start it. Yes, at some point, I may tell some of my patients, you know what, you can play with your estrogen a little bit. Like especially perimenopause, if you're having more hot flashes, you might have to add a little bit. And then if you're having fluctuations where your estradiol is high, you may have to pull away from your estrogen a little bit. That's different than giving them their testosterone and then they just kind of go on their way.
Yes.
And they have 6 months or a year's worth of testosterone, and then they're not getting their labs done. Who knows what their levels are, and if they're giving it to their friends or whatever else is happening. So I think, it can be it's frustrating. I know it's frustrating for our women. They also want some autonomy, and I think you can do that. And I think if you have a really great clinician that you're working with, I think that's easy to do, or a team, right? Because it's not just about the clinicians either, but utilizing their team. And so that was really important. There was kind of this overall, social media can be good and bad. I think that there's a lot of us out there that are educating appropriately, and I think there's a lot that are not. So that's all.
Very well said.
Kind of the story of social media.
Yeah.
Right.
Yeah.
Can you explain real quick, just because you said absolute risk versus relative risk, can you just explain that for the audience just so that they know what that means?
So your relative is
Okay.
the percentage
Okay.
change in risk between 2 groups, like treatment versus placebo. So but the absolute risk is the actual probability. So think of absolute is actual, the actual probability of something happening versus the percentage change between two groups. Does that
Gotcha.
make sense?
Yep.
Like you already said, Dr. We're all aging. So we all have risk factors. Like women have risk factors over men for some things, right? So we're
Yep.
all aging.
Yes.
And that's why what I've taken from the Menopause Society meeting is like the three things that I've heard so much is like holistic care, looking at the whole person, shared decision making, and that everyone's individualized, right? And that's
Yes.
where those discussions come in, is like we all are at risk for things, right? So,
Yes.
but we want to feel good on a daily basis and prevent and live a healthier health span. No,
Yep.
that's not the right way to say it, but you got, yeah, you got it.
Exactly.
But,
Exactly.
I also wanted to go back to what you talked about with hot flashes, because I know that you're, a big proponent of no hot flashing, but you're also a proponent of working with people. And so if someone came to you having hot flashes, and let's just say, I mean, moderate severity, right? We're not going to say super severe, but not mild, moderate severity. How much time would you give them to implement lifestyle changes before you would recommend treatment, right? Because you talked about obviously hormones, and then there's those non-hormonal treatments that people could do that
Yeah.
we listed out, but there's also lifestyle changes that they can do. So like,
Yeah.
yeah, tell me like a little bit about like how you would individualize that care, because I know that they can be risky, but we can also give them time to get rid of them.
Yeah. I honestly ask them, first of all, are you doing all the things that you should be doing? But sometimes they're not doing all the things because they feel terrible because of their hot flashes.
Right.
So that's the difference. So if they're not doing all the things, because even moderate, I think can still be so disruptive. If they're not sleeping, I treat those first for sure. And then they feel good and can implement those lifestyle changes. But sometimes they don't, they're like, you know what, I'm going to try doing these things first.
Yeah.
Especially if they're perimenopausal and maybe not having a ton of those flashes, or if it's cyclical for them. But if they're starting into that late perimenopause and moderate flashes, then I mean, I'm they're usually coming to me because they're ready.
Yeah.
They've already done a lot of those things, or they can't do them because they feel terrible.
Fair enough.
But I would say, because we know every time you have a hot flash, it's an insult on the brain, right? It causes those hyperintensities in the white matter of the brain, equal to uncontrolled high blood pressure, and can cause that vascular dementia or those cognitive changes long term. So not only that, increases your blood pressure and changes the cardiovascular system. I I cringe even every time I have one because I'm just like, oh my gosh, because we know what they
It's like,
do. I
protect
know,
it.
I know. I'm like, that's my heart, that's my brain. Okay, it's time to get these controlled.
Yeah.
But I think you really get a nice feel for those patients when you start talking with them, and usually by the time they come to me, they're ready. But we do talk about like your clean eating and your sleep and your hydration and are you exercising. But if they're so miserable, we do need to start that first so that they can actually make those changes because they're so miserable.
Yeah. Yeah. Yeah, it's
So
an interesting take, because I think when they come to me, and I don't know, Angie, if you experience this though, it is they want to do something that's not hormonal,
yeah,
right? They want to
yeah,
do so it's just, it is very different, because I do think that you see a lot of people that go to the doctor and they're like, just give me the hormones. And then you come to like the coaches and you're like, I don't want to do hormones, or I'm
yeah,
on hormones and they're not working, help me do
right.
other things. You know what I mean? So
Yes.
yeah.
Right, because we say this a lot, like that it's not, magic for everyone, and there's still so many other things that you have to do. So I can give you all the hormones in the world to make sure that you're as balanced as you can be. But if you are not eating healthy and you are not getting your sleep and you are not exercising, there's only so much that that's going to do for you to help you have, a healthier lifespan.
Yeah.
So, I think really the last key takeaway, our bullet point here was just education and empathy remain the most powerful prescription for adherence and satisfaction.
That's
So
nice.
true. It's so very true. And I find this just in my practice. And also that like you have to listen, you have to understand, and you have to continue to educate because it's so much information. I mean, I have an hour with my patients and there's still so much information. And, even on our follow-up visits, they're like, oh, I didn't know that. I'm like, well, we did talk about that. In my head, I'm thinking we did talk about that because it's part of like my spiel. But you can only take so much, So
Yes.
I think just continue to educate. And where I find we really need to continue educating is our perimenopausal women, because hormone therapy, as we've talked about before, is just that cushion, and some women do really well with just having a cushion in that chaos of volatility. And some women need to shut everything down to feel better, and that's okay too. And so, we vilify, hormonal options to shut your ovaries down, but for some women it works and they feel great, and that's okay. So we just need, and then some feel like they're failing hormone therapy because they still feel terrible month to month because they're fluctuating so much.
Right.
And so I just think we need to, just continue educating your patients on what perimenopause does. And when you just scribble all over the page, that's about right. So
I saw that post you
I
put
wish
on.
I would
I
have
was
been
like,
told that.
yes. Yeah.
yeah, I'm like, that's what happens,
Yeah.
because I'll get portal messages all the time. They're just like, oh, this worked. And now I feel terrible. I'm like, it sounds like your estrogen was high, and they're like, oh, I mean, that just happened to me too, where I had to add some, and then my mood went in the tank and couldn't figure out and pulled the extra estrogen off. And I was finally back to myself overnight. I mean, you know,
Yeah. Yeah. I was
so
thinking this morning, it's Halloween, and I'm like, I could just go dress normal because I'm just a science experiment. That's what I could go as Halloween. Perimenopausal
no,
women are
yes,
science
we
experiments.
are. And I tell my patients that all the time. I'm just like, we are not going to know until we try it. Go ahead, try that extra progesterone. It might work. It may not work.
Yeah.
We'll add a little dab here. Let's try that. But the more you tell me and the more you like journal it and the more information you can give me, we're really learning a lot about you. And it's fascinating, what those ovaries are doing and how they do it differently woman to woman, because everyone's different.
Yeah.
So
Yeah. Angie, I know you've had a little bit of a lag, so you haven't been able to jump in quite as much, but any questions, thoughts about everything that Dr. Hurdle gave to us? Like, what's your key takeaway of the key takeaways?
yeah.
Well, I think I feel like the three that being very holistic, like I
Mm.
love that was sort of the underlying message to providers. And again, like I just want women to know that it is shared decision making. I think you all have it down, but I often think it's women coming in and they don't know that. And that's one of the things
Right.
that both Jen and I do is, really teach, promote, empower women to come and advocate for themselves, but not tell you what to do. Because I hear what you're saying, Dr. Hurdle, because no one, you're the provider, but I do think there's such validity for women coming in with some knowledge and to start that discussion because of time as well. We only have so much time. You
Right.
only have so much time with your patients. I mean, I know you have an hour with your patients, but I'm saying just like the traditional
Yeah.
20-minute visit or
Yeah.
12-minute
15
visit.
minute.
Whatever.
Yeah.
So yeah. So I just, I feel like we're getting on the same page. Like, and I think that's
Yes.
really important for, patient and doctor centered, care. I mean, everyone wants that, right?
Yeah.
But the system isn't set up for that. So we just have to keep talking and, it's just, yeah. And then also just saying that, I mean, that no one's so individual, like we're all nuances. We all have different nuances and that's okay. And it takes time. It takes time and women have to be ready to participate as well and follow up and, get to that point with their provider that maybe they're able to play around with their hormones a little bit, but not right off the bat. Like
No.
So it's just, I love it all. And I'm glad you really put a, emphasis and the society as well on cardiovascular disease. And, with my education, we talk about that a lot, and then just listening to our bodies too, because when we're having heart issues, our heart attack signs are different than men. And we're trying to get that out there too. And women are
sleep apnea.
maybe, yeah. So thank you so much for really And Jen probably has something, but for me, I mean, I'm just so happy to speak with you today and take all of this out there.
Yeah. I mean, yeah, absolutely. Because we talk all the time about how our clients and our friends and our family, we want them to be seeing a menopause certified provider, right? And this is exactly why, because the Menopause Society is providing you a conference every year, in addition to monthly talks. All of this information is coming out to you. You are on the cusp of this new, medicine, new research, new what have you. And I just think that's so important that, because you still get to decide how to implement it, right? You're a doctor. There's
Yeah.
there's an art and a science to medicine and to nursing. And so you still get to take that and figure out how you're going to implement it. But just knowing that we have providers out there that are already on the cusp of it, I think is so important and what we should be looking for. I do want to ask you one question about like the vibe in the room, because I feel like this is really our, kind of our first conference since it's become menopause boom,
Yeah.
right?
Yeah.
So I'm curious, like,
So
were
full.
there more people? Was there a
Yes.
different vibe? Was it
Yes.
just,
Yeah, there was a lot of, I felt like new clinicians. I mean, I actually went with my daughter, who's a third year medical student, and her best friend, who they've been best friends since they were 4.
oh,
So she's
cute.
a physician assistant. So those two went with me. So that was really great. And there was a lot of younger new
Good.
clinicians that were there. So, they're learning for the first time. So that was really cool to see, there was a lot of people. And so, yeah, so which is really important. Now, I don't know if all of them, what type of clinicians they were, but yeah, it was well,
Good.
yeah,
That's
there
really
was a lot.
exciting to hear that
So,
there's
Sold
younger
out.
ones,
Yeah.
because I know we have that big gap since the WHI of these providers that were not educated,
yep,
until just recently, that now all of a sudden we can treat with hormones again, right? Like we have that big gap. So it's really good that we've got some people that are coming into the medical world that are going to have that knowledge too. So
yeah.
important.
No, it was really good. And I really think, even on the bone, that we had a really great bone lecture and about, our hormone therapy, using hormone therapy to prevent osteoporosis it was driven in. It was really, really good too. And it was good for, I think, our younger clinicians and less experienced clinicians to hear that as well, because we forget about
Yeah.
that it's one of the FDA approved, medications for the prevention of osteoporosis.
Okay.
So the bone lecture was fantastic as well. I don't know that I hit as hard on that, but it was very, very good. And I wanted to hit on one more thing that even Andrew was saying, about shared decision making. I think that one thing that we can remind patients are not used to that, right? So they're not used to
Right. Right.
going in and having a decision and sharing that decision with their clinician. And so, I love to say, hey, what if we do this? What are your thoughts on that? And don't be afraid to be like, yeah, or I'm not really sure. I'm thinking about this or that. But there is a change happening even in the insurance-based model of that shared decision making. I'd like to see it be a little bit quicker amongst all specialties, that you are sitting and you are talking with your patient, and your patient does, their thoughts, their concerns, and their ideas have value, and they should be discussing those with you. And if it's not correct, or if it's off base, then you just talk to them and be like, hey, this is why that wouldn't work. That's a really great thought, but that's not, whatever it is. So getting away from patients just saying, well, you just tell me what to do. We don't want to do that anymore.
Yeah.
We want to really work with you. It's a lot more fun.
Yeah.
So, we don't want to be
Absolutely.
that, like, you know, I guess not patronizing, but patriarchal type, situation where we're just telling you what to do all the time. So,
Yeah.
so really make sure that, you have a clinician and that you start doing that shared decision making, because maybe you may be the one that's not used to doing that, but start talking with them, start that journey. It's a lot more fun, and you'll get a lot more out of it too. So,
Absolutely. Very well said.
And we
Angie,
know
did
that
you have something else?
patients do better.
yep.
Oh, sorry. Yeah, I was just going to say that we know patients do better. They follow up when there's a shared, when they're in it, right? And
Yes.
they are a part of it. We know research has shown us that, right? That, but I do think that it is due to the system, right? And the time and like just, but I think, like you said, hopefully people are seeking care in all different areas, but, or arenas, but thank you. Yeah.
Yeah, thank you so much, Dr. Hertel. This was amazing. I do want to remind the audience, or it may be not a reminder, but a first time telling you that Dr. Hertel has been on twice, 2 other times prior to this. The first one we talked about perimenopause, the second time we talked about hormones. So if you want more information similar to what we just got, but like a lot and a lot more, because it's the full hour on each subject, please go check out those episodes. They are full of fantastic information. We love having you on, Dr. Hertel. Thank you so much.
Thank you again. I appreciate it. It's
you.
always a pleasure.
Yeah, thank you.